Every breath you take and every move you make, I'll be watching you. You know, when Sting wrote those famous lyrics, he probably wasn't thinking about an operating room.
Not likely, no.
Yeah. But you take that idea, that intense focus, and shift it into the world of clinical anesthesia, well, those words suddenly capture something really profound. It's this almost unsettling vigilance needed when monitoring a patient's breathing.
It really is. An attention that's so deep, so continuous, it's like mirroring the rhythm of life itself.
Exactly. And today, we are diving deep, immersing ourselves completely into this intricate, absolutely critical world of clinical monitoring during anesthesia. And look, this isn't just about the machines and the flashing lights,
No, not at all.
No, it's more like a meticulously choreographed dance.
Yeah.
It's this seamless blend of incredible human expertise and really cutting-edge technology.
Yeah.
And it's all designed for one main thing.
Yeah.
Your safety. We're aiming to give you this kind of shortcut,
Yeah.
to really grasp this field so deeply, so thoroughly, you'll feel like you've almost been there absorbing every key detail like an elite professional.
And that really is our mission for this deep dive.
Yeah.
We're going to unpack the essential standards that guide every single anesthetist. We'll look at the innovative technologies that boost their capabilities. And maybe most importantly, we'll get into the human factors. Those define optimal patient care, not just in the OR, but well, everywhere anesthesia happens.
Right.
And what's truly fascinating here, I think, is how seemingly small details, even just momentary lapses in attention, can have these really monumental implications for how patients do. We'll explore why every single piece of this system, from, most basic human listen, feel observation to the most advanced digital display, plays an absolute vital role in keeping you safe.
Okay, so let's start unpacking this core idea, clinical monitoring. At its very heart, the definition is about observing physiologic responses to surgery, procedure, and anesthesia. Now, for a certified registered nurse anesthetist, a CRNA, this isn't just like one part of the job.
No, it's fundamental.
It really is the essence, the very soul of their role. It's that constant, unwavering attention to how your body is reacting to the stress of surgery, reacting to those powerful medications being given. Try to imagine navigating this really complex, always changing environment, but you've got this array of super sensitive sensors and this rigorously trained co-pilot just constantly feeding you data, making split-second tweaks, anticipating every little turn.
That's a great analogy.
Yeah, that's kind of what this intense vigilance feels like.
It is, and the literature, the expert sources consistently emphasize that CRNAs must embrace this role with an obsessive, nearly compulsive approach. And look, that's not just flowery language.
No.
It's a foundational principle, and it's rooted deeply in patient safety. The value of these monitoring tools in reducing patient morbidity, that's, complications or illness and mortality, which is death. Well, it isn't just theoretical, it's incredibly well established. Years and years of rigorous research back this up.
Okay.
And this evidence gives us a crystal clear reason to support standardizing minimal monitoring. So what that means for you, the listener, is that there are these baseline requirements, right? A safety net of essential observations and technologies that absolutely must be met because they are scientifically proven to save lives and prevent harm. It's all about creating this safety system that's constantly active, continuously assessing, perpetually feeding back info to the clinician.
And this is where the human element for me just really shines. It's fascinating because despite all of the incredible technology that's revolutionized medicine, the primary source of information for any anesthetist, it's still the patient, right in front of them. Expert guidance in this field really stresses that the basic human senses, sight, hearing, touch, even, yes, smell, remain absolutely crucial tools.
Absolutely critical.
This isn't just some historical note. It's a living truth day in, day out. The guidance is pretty emphatic. Reliance on technology must never be allowed to lull the clinician into complacency. Just think about that phrase for a second.
It's powerful.
It really is. It underscores this deep, almost symbiotic need for a partnership. You need the tech, but you absolutely need that raw, unwavering human vigilance. You could have the fanciest monitor in the world, but if the anesthetist isn't also actively looking, listening, feeling, even smelling for those subtle clues, well, they're definitely missing critical pieces of the picture.
And to make sure this vigilance is consistently applied, professional associations play an absolutely crucial role. You have organizations like the American Association of Nurse Anaesthetists, the AAA, and the American Society of Anesthesiologists, the ASA. They are instrumental.
Okay, so what exactly do they do?
Well, their purpose is multifaceted but deeply impactful. They provide clear guidance for anesthesia providers, for hospitals. They meticulously evaluate the quality of care. They continually work to improve safety practices based on the latest evidence. And importantly, they educate the public on patient rights and what you should expect regarding anesthesia care. These aren't just like advisory groups. They effectively set the whole framework, the blueprint for safe and effective practice across the country.
Right.
So if we dive into, say, the ANA scope of anesthesia practice, it explicitly states, and this is quite profound, CRNAs are accountable and responsible for their services and actions and for maintaining their individual clinical competence.
Wow, that's a heavy
It
responsibility.
highlights this immense level of personal accountability. It means CRNAs aren't just, going through the motions. They're expected to deeply understand why they're doing everything, every decision, every action, and to stick rigorously to established standards. They are basically the vigilant guardians of that safety framework we're talking about.
And when you look at how these big picture standards actually translate into practice on the ground, there's a really clear, powerful alignment between the professions, right? The ASA standards for basic anesthetic monitoring, specifically Standard 2, it states very clearly, during all anesthetics, the patient's oxygenation, ventilation, circulation, and temperature shall be continually evaluated.
Continually. That's the key word.
Exactly.
Yeah.
The emphasis is squarely on continuous monitoring, not just checking in now and then, but maintaining this unbroken observational chain, a real-time dynamic picture of your physiological state from the very start of anesthesia right until the very end.
And going even deeper into those specifics, the evidence really underscores that during moderate or deep sedation, continuous monitoring of end-tidal carbon dioxide, ETCO2, shall be utilized to evaluate the adequacy of ventilation. This is non-negotiable. It's a critical point, a mandated safeguard.
Okay.
And it's even more explicitly required in certain situations, like when propofol, which is a potent sedative, is given during endoscopy procedures.
Why specifically then?
Well, because propofol can significantly depress breathing, and ETCO2 gives you that immediate, potentially life-saving feedback. But the guiding principle behind all these rules is clear. These are the minimum requirements. Clinical judgment, which is always informed by your unique situation as a patient and how complex the procedure is, should always prompt the anesthetist to go beyond these minimums when needed.
Right, you can always do more.
Precisely. And furthermore, if for some very rare reason a specific monitoring tool isn't being used continuously, it absolutely must be immediately available for use. Which, raises a pretty critical question for all of us. What happens when these standards, the very bedrock of safety, aren't meticulously followed?
Yeah, that's where we get these incredibly valuable insights from what are called closed claim studies. These aren't just, academic papers. They're essentially rigorous postmortems. Analyses of what went wrong in past anesthesia mishaps,
Yeah.
specifically cases that ended up in malpractice claims.
Learning from mistakes.
Exactly. And the good news, and it really is heartening, is that overall mortality rates tied to anesthesia have improved dramatically over the last few decades. This positive trend is down to a powerful mix of things. Vastly better respiratory monitoring, widespread use of evidence-based practices, things like surgical checklists becoming universal, better patient preparation before surgery, and critically effective communication, teamwork, and ongoing education within the healthcare team. It really shows the field's commitment to learning and getting better.
Delving into the specifics, though, the ANA Foundation Closed Claims Research Team, which was set up back in '95, has consistently provided some critical and, frankly, sobering data. In one evaluation of 123 preventable closed claims, errors in judgment were identified in over 65% of those cases.
Wow, over 65%. That's a lot.
It's 82 instances where potentially a better decision, a more vigilant approach, could have prevented harm. And these errors weren't just one thing. They covered a concerning range of issues.
Like what?
Well, fundamental failures to recognize, diagnose, and treat serious problems. Inappropriate anesthesia care for the specific situation. Poor preparation or planning before the procedure even started, the subtle influence of cognitive biases, mental shortcuts that can lead you astray. Then there's the pressure to speed things up, often called production pressure, which can compromise safety. A profound lack of vigilance, the exact opposite of that obsessive approach we mentioned, the dangerous idea of normalization of deviance, where unsafe shortcuts become so routine people stop seeing them as wrong. And critically, a lack of situational awareness, just failing to grasp the full dynamic picture of what's happening with the patient. These are complex human factors that, if you don't constantly guard against them with training and good systems, can unfortunately undermine even the best technology.
And here's a finding from one of those closed claims analyses, looking specifically at bad respiratory outcomes, that just hammers home the importance of what we're discussing today. It found in every hypoventilation claim, regardless of the type of anesthetic technique, a failure to optimally monitor the patient's ventilation was identified as a sentinel contributory practice pattern. Just let that sink in.
Every single time.
Every single time in those claims, a lapse in respiratory monitoring was a key factor. That's not a coincidence. It's a direct, undeniable link. It just dramatically emphasizes why continuous respiratory monitoring isn't just, nice to have. It's an absolute life or death necessity.
And we have seen concrete, truly game-changing examples of how technology has drastically improved safety. Think about esophageal intubation. That's when the breathing tube accidentally goes into the esophagus, the food pipe instead of the trachea, the windpipe.
Yeah, that sounds bad.
It's catastrophic. Before ETCO2 monitoring became widespread, this was a much more common and tragically often fatal error. But now, with that immediate, real-time feedback from ETCO2, which shows if there's carbon dioxide in the exhaled breath, meaning it's coming from the lungs, clinicians can instantly recognize that misplacement and fix it. It has literally transformed a potentially deadly event into something manageable. It's a powerful demonstration of technology's life-saving value when it's paired with human expertise.
Right.
And you can connect this to broader safety ideas. Think about the aviation industry. They've used rigorous incident monitoring systems for ages to learn from near misses and accidents. The level of vigilance needed in anesthesia is, in many ways, this ongoing proactive effort to stop critical incidents before they even start. But this human ability for vigilance isn't, foolproof. It's susceptible to external factors. Anyone who's spent time in an OR knows it can be busy, sometimes noisy. Things like ambient noise, music playing, temperature changes, even just the normal human interaction and conversation among the team. They can all subtly, or sometimes not so subtly, disrupt an anesthetist's focus.
And internal factors, too, I imagine.
Oh, absolutely. Then you have the internal factors that significantly impact that ability to stay constantly vigilant. Fatigue, boredom during really long, uneventful cases, sleep deprivation from tough schedules, circadian rhythm disruption from shift work, and unfortunately, even self-initiated distractions like, looking at your phone when you shouldn't be. All these things can subtly but significantly chip away at that constant hyper-focused attention that's required.
And as the monitoring tech gets more and more complex, more computerized, relying on intricate electronics, electricity, complex components, doesn't that create its own risks, like equipment failure?
That's a very important point. Yes, there is an inherently greater potential for equipment malfunction or even outright failure. This reality makes it absolutely essential for anesthetists to have backup methods ready, not just for monitoring, but critically for actually ventilating the patient. You simply cannot afford to put all your trust in one digital system.
Good point.
Furthermore, insights from the field show that the increasing trend of providing anesthesia care outside the traditional OR, maybe in radiology for an MRI, or a remote clinic, has been linked to more and more severe liability claims.
Really? Why is that?
It's likely due to a combination of unfamiliarity with these different environments, maybe a lack of the same robust, state-of-the-art monitoring equipment that's standard in a dedicated OR. It's absolutely crucial for the anesthetist to be acutely aware of these potential differences in gear and resources when working outside the usual controlled setting, and to ramp up their vigilance accordingly. Okay, so one of the big, yet maybe underappreciated challenges in managing all this information pouring in from electronic monitors is this phenomenon called alarm fatigue.
Alarm fatigue. Sounds exhausting.
It can be, and dangerously so. The AANA Practice Standard 9 specifically mentions that alarm limits and audible warnings should be actively used. It even recommends using variable pitch alarms and making sure threshold alarms are properly activated. The value of variable pitch, which you often hear with pulse oximetry, is particularly good because it can give you crucial auditory clues about subtle changes in oxygen saturation before you even look at the numbers. These alarms are fundamentally designed to protect you, the patient, by alerting the practitioner to increased risk and the immediate need to intervene.
But you said alarm fatigue is a problem, so the ideal doesn't always match reality.
Unfortunately, no. Alarm fatigue is a well-recognized type of human error where clinicians just become desensitized to a constant barrage of alarms. Think about it, if your phone buzzed every few seconds with unimportant notifications, you'd eventually just start ignoring it, right?
Yeah, probably.
The ideal alarm, as described in the literature, would be easy to locate, easy to recognize, obvious despite other noises, but still allow the team to talk. And critically, it would have very few false alarms. But many medical device alarms today, for various reasons, just don't meet that ideal.
And it leads to?
It leads to the dangerous practice of alarms being ignored or, even worse, deliberately silenced by practitioners. That creates a significant safety concern.
Why are there so many alarms if they're not critical?
That's the core of the problem. Many alarms that go off during an anesthetic are, in fact, clinically irrelevant. Only a very small percentage actually signal a truly critical event. So it's maybe not surprising that there hasn't been a lot of progress in combating this alarm fatigue, and this often leads to a dangerous kind of cognitive error.
Cognitive error.
Yeah, where the practitioner dismisses valid critical data as just being wrong, often because of unconscious biases or just a failure to analyze the whole complex situation. There is a classic, tragic example often cited. A pulse oximeter keeps alarming, indicating a potential oxygen problem. But instead of recognizing actual hypoxia, low oxygen, or hypoventilation, the provider just focuses on reapplying the probe to different fingers or toes, thinking it's just a technical glitch.
Wow. That powerfully shows how human interpretation, maybe skewed by fatigue or bias, can dangerously override critical warnings from the text.
Precisely.
So if the technology alone isn't the perfect answer and the alarms themselves can cause problems, what is the solution? How do you navigate this?
The answer, as the evidence points out, lies in adopting a systematic process. That's identified as the most effective way to reduce anesthetic complications and deaths. It's not just about what you monitor, but fundamentally how you monitor. And even more importantly, how you accurately interpret that continuous stream of information to allow for timely, life-saving intervention. It's about building a consistent, methodical, robust way to process complex medical data under high-pressure conditions.
Okay, a systematic process.
Yeah, and if you connect this to the bigger picture, you can clearly see anesthesia monitoring through the lens of quality assurance and crisis management principles. The very act of giving anesthesia, plus the surgery itself, causes a wide range of physiological responses in you, the patient.
Right.
These responses need constant, systematic observation. A truly proactive approach means this almost obsession-like commitment to vigilant observation, using all your human senses plus the sophisticated tech aids. This involves developing a deeply ingrained habit of systematic monitoring, a routine that can significantly cut the chances of an unnoticed bad response escalating. This often includes a deliberate routine practice of sweeping the anesthesia field.
Sweeping the field, what's that?
It means visually scanning everything in a methodical loop. The patient, the anesthesia machine, the breathing circuit, all the monitors, over and over, ensuring no critical detail gets missed.
That makes sense. So this systematic approach often starts with familiar concepts, right? Like the ABCs.
Exactly. We all know the mantra. Airway, breathing, circulation. Those three remain absolutely foremost and critical in anesthesia monitoring. But as research has evolved, experts have highlighted expanding this basic framework to ABCD, adding D for evaluating drug effects.
Ah, okay. Accounting for the medication.
Precisely. This gives you a more comprehensive foundational monitoring approach that considers the powerful drugs used in anesthesia.
And are there more detailed systems or algorithms for this? Especially for crises.
Yes. Building on that, the crisis response algorithm can be expanded even further to make it easier to remember and use under pressure. It's often remembered using the mnemonic cover ABCD. It systematically guides the anesthetist through a series of critical checks in a rapid, logical sequence.
Cover ABCD. Okay, break that down for us.
Sure. C is for circulation and color. Check circulation adequacy, pulse, blood pressure, ECG. Check oxygenation visually and with pulse oximetry. O is for oxygen and oxygen analyzer. Check the O2 delivery system. Is the supply okay? Is the hypoxic guard on the machine working? V is for ventilation and vaporizer. Manually ventilate the patient, check circuit airway patency. Watch chest rise, listen with the stethoscope, check ETCO2, verify the anesthetic vaporizer function. E is for endotracheal tube. If there's a tube, check it thoroughly. Patency, is it blocked? Seal, is it leaking? R is for review monitors and review equipment. Systematically review all monitors. Are they calibrated, maintained? Review all equipment touching the patient.
Okay, that's cover. What about the ABCD part again?
Right, then you cycle back through the basics, reinforcing and reevaluating. A is for airway. Detailed check of airway patency. Non-intubated airway, okay. Check for laryngospasm, foreign body obstruction, bronchospasm. B is for breathing. Assess breathing pattern, rate, depth. Examine, listen to the chest, review EtCO2 and pulse oximeter again. C is for circulation. A quick repeat assessment of circulation. Reevaluate after any interventions. D is for drugs. Review drugs given. Consider needing other drugs, like antidotes. Critically, consider if a medication error might have occurred.
Wow, that's comprehensive. It feels like a pre-flight checklist for the body.
In a way, yes.
Now, what's important to grasp here, I think, is that while maybe studies haven't absolutely proven that these specific algorithms always improve outcomes in every single case.
Right, the direct link can be hard to isolate sometimes.
But it seems intuitively, overwhelmingly clear how incredibly useful aids like this can be, especially when things go wrong under immense pressure. They seem pivotal in developing that inclusive, vigilant approach to routine monitoring we talked about, and they systematically guide better, faster responses when critical incidents happen, especially with airway or breathing events. They're like mental frameworks, ensuring nothing gets missed when time is critical.
Exactly. They provide structure in chaos.
Okay, let's really zoom in now on respiratory monitoring. Fundamentally, this starts with the observance of gas exchange from the upper to lower airways. This assessment has to be continuous, right through the entire perioperative journey. It's the absolute essence of making sure you, the patient, are breathing effectively and safely.
Clinically, this involves constant observation, watching the ventilatory movement of your chest, noting immediately any signs of airway obstruction, things like retractions where the skin sinks in around the ribs or neck, or that seesaw motion of the chest and abdomen. Even something as simple as seeing condensation, like fogging, inside an airway device or a face mask can show the presence of gas exchange.
But not necessarily how good it is.
Exactly. It doesn't confirm adequacy. And this is where those human senses, as we mentioned, are just invaluable. The sense of touch, for instance, can help feel subtle air movement on the anesthetist's hand near the airway. Smell can actually be the very first alert to a disconnected circuit, especially if volatile anesthetic gases are being used. And of course, keenly listening for abnormal airway sounds like stridor, that high-pitched, harsh sound of upper airway obstruction, is absolutely crucial.
You mentioned the precordial stethoscope earlier. Even with all the electronics, it still has a role.
Experts in the field specifically highlight it as a valuable tool in auscultating the presence or absence of airway exchange during all phases of the anesthetic. Yes, its use has diminished with all the sophisticated electronic monitors, but its importance for teaching new practitioners those vital, close monitoring habits, that cannot be overstated.
How so?
It forces this direct, continuous, intimate connection to the patient's breathing. It fosters a fundamental skill that just looking at digital readouts alone can't provide.
Got it. And what about when there's a breathing tube, like an ETT or an LMA?
Right, when an endotracheal tube or laryngeal mask airway is used, verifying its correct placement and ensuring adequate ventilation must include several things. Assessing breath sounds over both lungs, watching for symmetrical chest expansion, and crucially, confirming the presence of carbon dioxide, CO2, in the expired gas, that end-tidal CO2 or EtCO2.
That EtCO2 check seems really vital.
It is profoundly life-saving. The experts state it with real gravity. Whereas failure to successfully intubate is problematic, failure to recognize misplacement is catastrophic. A tube in the wrong place, like the esophagus. That's an immediate deadly threat. EtCO2 monitoring provides instant, undeniable proof of correct placement in the trachea.
Okay, so beyond just knowing the tube is in the right place, general respiratory monitoring is about ensuring adequate, minute ventilation. How much air is moving?
Exactly. How much air is actually moving in and out of your lungs per minute? Just seeing the chest move isn't enough. You need to know how much air and how effectively. And while checking skin and nail bed color for cyanosis is part of the overall assessment, it is, importantly, not a reliable measure of adequate ventilation or oxygenation.
Oh, why not? Isn't blue skin a sign of low oxygen?
It is, but cyanosis, that bluish color, is a very late sign of hypoxia or anemia. And it can be incredibly hard to assess accurately due to things like OR lighting or differences in individual skin pigmentation. What the closed claims studies consistently show as the most prominent theme regarding safety is the invaluable role of specific monitors and their alarms. Pulse oximetry, EtCO2 measurement, oxygen analyzers, and disconnect alarms. And just as important is the anesthetist making sure all these devices are working properly before starting the anesthetic. That pre-use check is critical.
Are there newer technologies emerging in this area too?
Oh, absolutely. New technologies are constantly coming online to enhance respiratory monitoring. Acoustic monitoring transducers, for example, show significant promise. These devices measure respiratory rate by sensing turbulent airflow through a small sensor placed on the upper airway.
How well do they work?
Remarkably well, even despite a patient's size or background noise, which can sometimes limit a traditional stethoscope. While they don't identify specific sounds like stridor, they can quickly and reliably alert the team to apnea when breathing stops. Another fascinating innovation is the non-invasive respiratory volume monitor, or RVM.
RVM, what does that do?
Using electrodes on the patient's chest, these devices measure respiratory rate, tidal volume, how much air in each breath, and therefore minute ventilation, total air per minute. They can record trends over time and have actually been shown to be more sensitive than capnometry in spotting hypoventilation in sedated patients. They could potentially become a really widely used tool for monitoring spontaneous breathing.
Interesting. Now moving to more direct measurements. Arterial blood gas analysis, ABGs.
Yes, ABG analysis gives you a precise snapshot of CO2 levels directly in the blood. Think of CO2 as your body's exhaust gas. The amount in your blood tells us exactly how well your lungs are venting it and also how fast your cells are burning fuel metabolically. It's a precise, quantitative look at your internal engine's efficiency and balance, giving crucial insight into your acid-base status.
And building on that chemistry, you mentioned disposable colorimetric EtCO2 detectors, those little color-changing devices.
Exactly. Simple yet ingenious. They react to pH changes when CO2 is present, showing a rapid color change. They're widely used in emergencies to quickly verify ETT placement, but there are nuances.
Such as?
Well, it's suggested you need at least 6 breaths for an accurate reading to avoid misinterpretation. And you can get false positives, say, from CO2 pushed into the stomach during mass ventilation or even from fizzy drinks or antacids the patient had earlier. So even with simple tech, critical interpretation and knowing the pitfalls is key.
But the main tool for continuous CO2 monitoring is capnography, right?
Yes. Continuous EtCO2 monitoring, often called capnography, is the real workhorse in the OR and beyond. The evidence confirms it provides a practical, non-invasive, and accurate reflection of arterial blood carbon dioxide, and it is, by far, the most common means of assessing ventilation during anesthesia. It's an absolute standard of care during general anesthesia and moderate or deep sedation.
How accurate is it compared to an ABG?
Remarkably accurate in many cases. EtCO2 is typically only 2 to 5 torr lower than arterial CO2 in patients without significant heart or lung problems. However, and this is vital conditions that increase dead space in the lungs or mess with hemodynamics like low blood pressure, will increase that difference. So you always have to interpret the EtCO2 number within the patient's full clinical context.
You mentioned capnometry versus capnography. Can you clarify those terms?
Sure. Capnometry just measures the CO2 number in the gas. Capnography refers to the continuous analysis and recording of that measurement over time. And the capnogram is the actual waveform, that continuous graphic display of CO2 levels through the phases of breathing. So you get the number, the trend recording, and the visual waveform all providing vital info.
And how does the technology actually measure the CO2?
It uses highly precise infrared analysis. The basic principle is pretty neat. Different gases absorb infrared light at unique wavelengths. By detecting CO2's specific absorption pattern and filtering out other gases, the machine gets a precise quantitative CO2 measurement.
Okay. And you mentioned 2 ways of sampling the gas, mainstream and side stream.
That's right. 2 primary methods for sampling the gas from your breathing: non-diverting, also called mainstream, and diverting, or side stream.
What's the difference? Let's start with mainstream.
Okay. A non-diverting mainstream monitor measures the gas right in the breathing system. The sensor fits over a connector very close to the patient's airway. The advantages are minimal time delays because the gas doesn't travel far, fewer disposable parts, and no need for scavenging gas since it stays in the circuit.
Sounds good. Disadvantages.
Well, it usually only measures CO2 and maybe nitrous oxide, not other anesthetic gases. The adapter itself adds a bit of dead space to the circuit. It's prone to interference from condensation or secretions fogging up the sensor. The weight of the sensor and cable can pull on the breathing tube, risking disconnection, and it's generally hard to use with patients who aren't intubated.
Okay, so what about the other type, diverting or side stream?
A diverting monitor pulls out a small sample of gas through thin tubing positioned near the patient's airway. It pumps this sample to the main monitor unit for analysis. The downsides are you need to scavenge these sampled gases, and the sample tubing can get blocked by moisture or secretions.
But what are the advantages?
The advantages are significant and often make it preferable. Minimal added dead space for the patient. Huge versatility, the sampled gas can also be sent to analyze anesthetic agents. And critically, the small, light tubing is easily adapted to sample from awake, spontaneously breathing patients via the mouth, nose, or even under a simple oxygen mask.
Ah, so that versatility is why it's used more outside the OR, for sedated patients who are breathing on their own.
Precisely. Even though ambient air or supplemental oxygen might dilute the sample a bit, giving a slightly lower EtCO2 reading, its value as an early warning for hypoventilation or oversedation has become incredibly clear and life-saving. For instance, in the ER, EtCO2 monitoring has proven much more sensitive than just watching the patient or even pulse oximetry for picking up breathing problems, especially when patients get extra oxygen, which can hide how poorly they might actually be breathing.
Right, the pulse ox might look okay even if they're not breathing enough.
Exactly. So many studies now strongly suggest that, just like pulse oximetry, EtCO2 monitoring should be considered a standard of care for patients getting sedation anywhere outside the operating room. That's a huge evidence-driven shift in practice, really emphasizing its importance.
Now, about that capnogram waveform itself, you said understanding it is a necessary skill.
Absolutely essential. It's not just about the number. The unique shape of that waveform gives you a wealth of dynamic, real-time information. It lets practitioners rapidly tell the difference between normal and abnormal breathing patterns, whether they're caused by the patient's own lung issues, problems with the anesthesia machine, or unexpected responses during anesthesia. Think of it as a dynamic, living graph of each breath.
Can you walk us through a normal waveform? You mentioned 4 phases.
Yes. A normal time capnogram, the kind you'd ideally see with mechanical ventilation in an intubated patient, has 4 basic phases. Picture it like a little rectangular wave. Phase 1, baseline, AB. This is the end of breathing in, start of breathing out. Gas here is from the anatomical dead space, like the trachea, so it should have basically no CO2. The line should be flat at 0. Any rise here is a red flag. Phase 2, expiratory upstroke, BC. Now, a mix of dead space gas and alveolar gas from the lungs comes out. CO2 levels rise rapidly. This is the sharp upwards slope of the waveform. Phase 3, expiratory plateau, CD. This is the main part, where gas-rich and CO2 empties from the alveoli. In healthy lungs, this line is nearly flat, showing consistent CO2 levels coming out. It's the longest part. The actual EtCO2 number is measured right at the very end of this plateau. Point D. That's your peak CO2 reading. Phase 4, inspiratory downstroke, DE. Inspiration begins, fresh air or oxygen rushes in, pushing CO2 levels rapidly back down to near 0. This is the sharp downward slope completing the rectangle.
Okay, that's the normal shape. But you said variations tell you things. It's like a language.
Exactly. That's what makes it so powerful. Subtle changes or specific shapes tell you a huge amount about what's going on. For example, if the baseline in phase 1 doesn't return to 0, that immediately screams CO2 rebreathing. Big problem. Could be inadequate fresh gas flow, or worse, the CO2 absorbent in the machine is exhausted and needs changing immediately. Or if phase 3, the plateau isn't flat but slopes upwards, that indicates prolonged expiration. Maybe there's an obstruction somewhere, or a ventilation perfusion mismatch in the lungs, like in COPD, or even just a kinked breathing tube. Any slope there needs investigation. Sometimes you see little cardiac oscillations, regular small sawtooth waves on the plateau, matching the heart rate. It's the heartbeat subtly moving gas in the chest, usually benign, especially common in kids. And then there's the cure air cleft. This is a dip or notch in the plateau during mechanical ventilation. It's a critical sign. The patient is trying to take a breath on their own, means the anesthesia is too light or the muscle relaxation isn't enough, needs immediate action.
So the shape is as important as the number. And what about the number itself, high or low EtCO2? What can cause those?
Right. Understanding the causes of high and low EtCO2 is vital for troubleshooting. It's detailed in box 18.1 in the source material, but basically, increased EtCO2 can mean increased CO2 production in the body, like fever, sepsis, seizures, malignant hyperthermia, releasing a tourniquet. Or it means hypoventilation, not breathing enough, due to COPD, deep anesthesia, drug side effects. Or it could be equipment problems, absorbent failure, ventilator leak, rebreathing. Decreased EtCO2 can mean decreased CO2 delivery to the lungs. Think low blood pressure, cardiac arrest, pulmonary embolism, shock, hypothermia. Or it can mean hyperventilation, breathing too much or too fast due to pain, anxiety, light anesthesia. Or again, equipment problems. Ventilator disconnection, esophageal intubation where it would be near 0 airway obstruction, leaks around the tube.
That's a lot to keep track of, but it sounds like it gives the anesthetist a really systematic way to figure out what's wrong very quickly.
Precisely. It allows rapid diagnosis and correction, often in just seconds.
Now, beyond capnography, you mentioned modern machines have spirometry loops. pressure volume and flow volume loops. How do they help?
Yes, these offer even more advanced insights into the mechanics of breathing. They provide a powerful, immediate visual way to rapidly evaluate changes in lung compliance and resistance. It's like getting an instant picture of how stiff or obstructed the lungs are.
Okay, let's define those. Pressure volume loops.
Pressure volume loops plot the volume of air going in, vertical axis, against the airway pressure needed to push it in, horizontal axis. These give you crucial insight into lung compliance.
And flow volume loops.
Flow volume loops show the speed of airflow, vertical axis, against the volume of air moved, horizontal axis. These give you real-time information about pulmonary resistance.
Okay, let's dig into compliance first. What is it exactly?
Lung compliance refers to the forces that oppose lung expansion. Think of it like inflating a balloon. How easily does it stretch? Ideal compliance means it takes little pressure to inflate the lungs a lot. The loop is tall and upright. Low compliance means the lungs are stiff. You need high pressure for little volume. The loop flattens and shifts right.
What causes low compliance?
Many critical things. Pulmonary embolism, bronchoconstriction, collapsed lung, pneumothorax, pressure from abdominal insufflation in laparoscopic surgery, even just not enough muscle relaxation making the chest wall stiff.
And high compliance.
You might see increased compliance in conditions like emphysema, where lungs lose elasticity, or when using PEEP, positive end expiratory pressure, which helps keep airways open.
Okay, and how does resistance show up on these loops?
Increased resistance, maybe from a kinked tube, airway obstruction, or bronchospasm manifests clearly. On a pressure volume loop, it takes more pressure to deliver the same volume. On a flow volume loop, you'll see a characteristic change, often a scooped-out appearance during exhalation, showing that air is having trouble getting out of the lungs. These loops are incredibly powerful diagnostic tools, giving instant visual feedback on breathing mechanics.
We've talked a lot about breathing and oxygen, which is obviously critical, but you made a key point earlier. Hypoventilation, high CO2, even respiratory arrest can happen, even if oxygen levels look okay, especially with supplemental oxygen.
That's right. It highlights the need for a truly holistic approach.
Which brings us to something seemingly simpler but still profoundly important, temperature monitoring.
Absolutely. Both the ANA and ASA standards unequivocally support continuous temperature monitoring during anesthesia. It's essential to catch rare but dangerous hyperthermia, but much more commonly, the big concern is hypothermia. That's defined as a core body temp below 36 degrees Celsius or 96.8 Fahrenheit.
And how common is hypothermia during surgery?
The statistics are quite striking. Around 70% of postoperative patients, and some estimates go as high as 90% of all surgical patients, experience some degree of hypothermia. And unfortunately, this can lead to a whole cascade of negative effects.
What kind of risks are we talking about with hypothermia?
They're significant and surprisingly varied. Things like a higher risk of wound infection and delayed healing, increased oxygen consumption from shivering afterwards, which stresses the heart, and elevated risk of cardiovascular problems, even heart attack. It interferes with blood clotting, increasing bleeding risk. For patients with sickle cell disease, it can trigger painful crises. And beyond direct harm, it leads to longer stays in the recovery room, PCU, which increases the cost of care. It's this cascade of bad outcomes that largely can be prevented with good monitoring and management.
So it's not just about patient comfort, it's about serious outcomes.
Precisely. And that's why national quality improvement initiatives, backed by big players like CMS, actively promote keeping patients normothermic at a normal body temperature as a key way to prevent a wide range of post-op complications. What's really fascinating here is how understanding why temperature changes happen is so critical to appreciating why continuous monitoring is vital. It's not just about treating hypothermia after it happens. It's about proactively preventing it by anticipating, monitoring, and intervening early.
How does the body normally control temperature? And how does anesthesia mess with that?
Well, thermoregulation is complex. It involves sensing temperature, central control on the brain's hypothalamus, and then responses to adjust temperature. When you're awake, your main defense is behavioral, putting on clothes, seeking warmth, moving around.
Right.
But anesthesia takes away those conscious responses. So you have to rely on autonomic things like shivering, blood vessels constricting to save heat, or sweating to cool down. The problem is general anesthetics significantly lower the thresholds for shivering and vasoconstriction. Your body just doesn't try to warm itself up until it's much colder than usual. Even regional anesthesia, like epidurals or spinals, causes hypothermia by disrupting nerve signals and causing vasodilation.
So normothermia, normal temp, is about 37 Celsius for 98.6 Fahrenheit.
Yep.
You mentioned core versus peripheral temperature.
Yes, there's usually a difference between your internal core temperature and your skin temperature. Where you measure matters. And while hypothermia is the big worry, hyperthermia core temp over 38C or 100.4 F can also happen. Malignant hyperthermia, MH, is a rare genetic condition triggered by certain anesthetics that causes a massive metabolic surge in fever that alone mandates continuous temperature monitoring during general anesthesia. Other causes of fever could be infection, other hypermetabolic states, even certain drugs like atropine, which stops sweating.
But hypothermia, below 36C, is much more common. What causes that heat loss in the OR?
Multiple things contribute. The cold OR environment is a big one. Studies show patients in rooms at 21C, about 70 F, will all get hypothermic just from the room. Most heat loss is your body radiating heat to the cooler surroundings. Then there's evaporative loss from wet skin, prep solution sweat, or breathing out warm waste air. Convective loss from cool air moving over you, and conductive loss from direct contact with cold surfaces like the OR table.
Plus, the anesthesia itself makes it worse.
Yes, a major factor is the redistribution of blood. Anesthesia causes vasodilation, widening blood vessels. This brings cooler blood from your arms and legs into your core, dropping the core temperature. Both general and regional anesthesia inhibit thermoregulation and cause this vasodilation. That's why continuous monitoring is so crucial. And because normal core temp varies, monitoring continuously lets you see trends and start active warming early, rather than just getting occasional snapshots.
Do the standards say exactly when temperature must be monitored?
They allow some clinical judgment, but the AMA standard is quite specific. When clinically significant changes in body temperature are intended, anticipated, or suspected, monitor body temperature. Use active measures to facilitate normothermia. When malignant hyperthermia, MH triggering agents are used, monitor temperature and recognize signs and symptoms to immediately initiate appropriate treatment and management of MH. That gives a solid framework.
Are some patients more at risk for hypothermia than others?
Definitely. Risk factors include being sicker overall, higher ASA status, having long or major surgery, combining epidural and general anesthesia, long procedures, being elderly, or having low body fat. And interestingly, one identified risk factor is simply failure to monitor temperature itself.
Wow. That really underscores the importance of doing it.
It really does. It shows that monitoring leads to action, which prevents the problem.
What technology is used for monitoring temperature?
Various types. Thermistor, thermocouple, and platinum wire devices are common with electronic monitors. They're generally accurate and reliable for continuous readings. Liquid crystal strips for the skin are convenient and non-invasive, but generally lack the accuracy needed for precise core temperature monitoring, and readings can vary between observers.
And where do you measure temperature? You mentioned core sites are best.
Yes, core temperature sites are considered most reflective of the body's true thermal state. Each site has pros and cons, though. Table 18.4 in the sources details this. Skin. Easy, non-invasive, but unreliable for core temp. Too affected by the environment. Temporal artery. Uses infrared. Popular, but accuracy for core temp in the OR is debated. Core sites, better. Tympanic membrane, eardrum, can be very accurate if a contact probe is used. It's close to the brain's temp control center, but less reliable with non-contact infrared devices. Distal esophagus, good core reflection in many surgeries. Bladder, correlates well with pulmonary artery temp, especially in long surgeries like liver transplants. Nasopharynx, another reliable core site. Pulmonary artery, often considered the gold standard in critical care, but requires an invasive catheter.
So the choice depends on the surgery and the patient.
Exactly. The anesthetist needs to choose the most appropriate, reliable site for continuous monitoring based on the whole clinical picture.
So we've covered all this sophisticated monitoring, stringent standards, advanced tech, but it really seems to boil down to the human element, doesn't it?
Absolutely. Experts consistently emphasize that teaching clinical monitoring starts in the classroom, laying the theory, but it's fundamentally reinforced, refined, and deeply ingrained in the real-world clinical learning environment. It's a complex blend of art and science that has to be meticulously taught, rigorously practiced, and truly learned through experience.
And simulation plays a role here, too.
A crucial role, yes. Simulation-based education is an invaluable supplement to direct clinical experience. It provides a safe space for interactive practice, letting students and even experienced pros review critical incidents and adverse events without any patient risk. This repetitive, high-fidelity exposure is key for developing critical decision-making skills through repetition and helps embed those systematic approaches, like cover-app CD, making them second nature.
But there's a challenge with students focusing too much on the screens.
Yes, it's a commonly observed challenge. Students can tend to focus intently on the electronic devices first, sometimes inadvertently neglecting that ongoing, vital physical assessment of the actual patient right there. So the instructor's role is vital, actively promoting those effective holistic routines, explaining the why behind every action, and critically, setting an example through their own meticulous practice.
You also mentioned training the senses, really learning to notice subtle changes.
Incredibly important. It's a skill that truly separates the novice from the expert, and it's not something a textbook alone can teach. Every anesthetist, for instance, should be able to tell, just by sound, when the pitch of the pulse oximeter tone is dropping, indicating decreasing oxygen saturation before they even look at the screen. Similarly, they need to rapidly recognize faint, abnormal airway sounds through a precordial stethoscope, like the early wheeze of bronchospasm. These are fundamental, basic clinical skills essential to anesthesia practice that just take time, repeated experience, and deliberately cultivating the right habits to develop fully. They represent that indispensable human overlay, that interpretive layer that no machine can truly replicate.
And part of that expertise is knowing when the machine might be wrong, dealing with artifacts.
Critically important. Both students and experienced providers must deeply appreciate the potential for artifacts, false signals, and electronic measurements. Because these artifacts often cause false alarms, there's a real danger that truly important, valid alarms might get ignored if the system cries wolf too often. Therefore, the ability to assimilate all data to make the right interpretation, combining insights from all human senses, all monitors, all clinical knowledge and experience is absolutely vital. It's about being a master interpreter of this complex, dynamic symphony of information where every note, every waveform, every subtle shift holds meaning for patient safety. Hashtag outro.
So as we wrap up this really deep dive into the fascinating critical world of clinical monitoring during anesthesia, I think the core takeaway is crystal clear. While technology has undeniably advanced, the anesthetist's ability to monitor vital functions in ways we couldn't have imagined before.
Incredible advancement.
The importance of the human factor in anesthesia delivery and monitoring, well, it just doesn't appear to be replaceable anytime soon. It's a powerful testament to the absolute necessity of human expertise, judgment, and vigilance.
Absolutely. Clinical monitoring is, right at its heart, a profoundly human skill. It actively uses all the senses, just augmented by technology. And those critical findings from the closed claim studies, especially around oxygenation and ventilation, have powerfully hammered home the non-negotiable need for vigilant, continuous monitoring of these things in every single patient under anesthesia. This isn't just best practice. It's a foundational, life-saving safety requirement, proven over and over.
We've explored how having a systematic approach helps keep the anesthetist vigilant, making sure nothing gets missed. And of all the tools, EtCO2 and pulse oximetry really stand out as being particularly life-saving, with tech constantly improving them. And we can't forget hypothermia. It happens so often and requires that constant, prudent temperature monitoring and proactive management to avoid its risks.
Ultimately, this deep dive really highlights the ongoing importance of unwavering adherence to rigorous clinical standards of care, the ones developed and refined by the professional anesthesia organizations. These standards need to be followed constantly and reevaluated as new knowledge and tech emerges. And we always need good outcome studies to justify using monitoring tools, ensuring the benefits truly outweigh any risks. If we connect this to the bigger picture, it's about this constant, dynamic evolution of safety, driven by both relentless innovation and that unwavering human vigilance, all working together to ensure the safest possible journey for every single patient.
So what does all this mean for you, the listener, the patient, or even the future of healthcare? Maybe consider how this intricate, really profound balance between human intuition honed by experience and systematic approaches, and that cutting-edge technological precision will keep redefining the very boundaries of medical safety. What truly stands out to you about this incredible blend of art and science that goes into quite literally every single breath you might take under anesthesia? We definitely encourage you to continue your own deep dive on this fascinating and truly vital topic, because understanding it really means understanding the cornerstone of modern medical safety.